to developing and implementing an employment equity plan in line with the Employment Equity Act number 55 of 1998 as amended. And this act aims to promote equal opportunities and fair treatment in employment by eliminating unfair discrimination. SAPS has made significant strides in achieving a broadly representative workforce at all levels. Transformation and diversity programs are actively implemented to promote a non-racial and non-sexist organization. Continuous work sessions are conducted to sensitize employees on transformation and diversity management. While notably progress has been made in gender representative at the top management level, there's still work to be done from salary level 14 downwards due to SAP's historically male-dominated environment. The organization is dedicated to promoting the rights of persons with disability, encouraging them to disclose their status to provide reasonable accommodation. And to amplify the voice of persons with disabilities, disability task teams have been established at both national and provincial level, and these teams meet quarterly to discuss the implementation of disability programs and address challenges that hinder full participation. Despite ongoing efforts, the representation of persons with disability remains below the minimum target of 2%, which target, I think it was set many years ago, which has now been increased to 3%. The current representation stands at 1.73%. Yes, we are not there yet. We haven't achieved our target. And we're only having 3,175 employees out of the 183,075. I think we can maybe indicate that the reason for us not meeting this target, it might be because of the nature of our work, because the nature of functional policing roles requires physical fitness and poses a challenge in recruiting persons with disability for entry-level positions. Just to give also a picture in terms of our race representation, and we are saying Africans in the organization were actually 79.74%, and we are supposed to be at 80%. And the colors, they're 11.26, and they're supposed to be 9.27. And Indians, they are 2.3%, and they're supposed to be at 2.6%, and whites 6.77%, and they're supposed to be 8.0%. You can clearly see where we are having some gaps, and we need to, put some measures in place to make sure that we achieve all these targets. And in as far as the career representation, males and females are concerned on level 13 to 16, our target is 50-50, and we are 59.78% males and 40.22 females, and level 8 to 12 is 58.80, and females are 41.20. We are not achieving our target as well there, but we are closer. And for levels 1 to 7, 60.17, and females is 39.83%. And overall, we are having 60% males and 39.98 males. So we still have a long way to go when you look at the overall picture. But I know that with the current intake, we made some good strides in terms of recruiting more females to make sure that we balance the gender in the organization. Issues of discipline, the minister highlighted in 23-24 financial year. We can indicate that we recorded 4,390 allegations of misconduct involving 6,105 employees, representing 3.3% of the workforce of 183,000. This included assault, AWOL, absent without leave, theft, allowing prisoner to escape, improper conduct, and corruption, which was also highlighted by the minister. And we also observed that sergeants and constables accounted for 40% of these cases, meaning that we are having a challenge at the lower levels. So the commission that will be dealing with the issues of misconduct, if you can come up with some wisdom of Solomon to assist us, in terms of making sure that our lower levels, they get proper programs that will stop them from committing all these acts of misconduct. And by the 31st of March 2024, we managed to finalize 57% of disciplinary cases with outcomes including 609 not guilty, 84 cases were withdrawn, and 213 final written warnings, 195 suspensions without salary, and 356 dismissals. I know there are talks there that we are not dismissing our members, but we do dismiss our members, but it is not a good thing to do. But unfortunately, if they go the other way, we need to also act. Most dismissals involved constables, sergeants, and warrant officers, posing a risk to SAPS return on investment. To address delays in finalizing cases due to capacity issues, SAPS is consulting with labor at the SSBC to establish a dedicated disciplinary unit investing in training and development to build capacity. I know Mr. Gareth Newham, at some point we also had a discussion about this establishment of the trial units. Yes, they are still on the table, but it's just taking too long at our council. It's something that we cannot conclude or finalize on our own, but we are almost there. Because if we don't have dedicated teams to deal with discipline, we'll forever experience the delays in finalizing some of these cases. Then, in as far as EHW is concerned, we're having about 132 psychological professionals, 37 quality of work life experts, 196 social workers, and 186 chaplains. Support provided to 96,721 employees. And the key programs that were addressed is mental health awareness, resilience building, diversity awareness, gender-based violence support, and ethical awareness. And capacity building sessions, about 1,366 sessions were conducted, and EHW managed to reach 20,489. And trauma debriefing, 3,702 employees were supported. And declined cases reduced from 15 to 18. And fitness partnership, we do have a MOU with Planet Fitness and Vision Active for discounted membership. We are giving you this picture because the commission that will also be looking at the programs that we are offering. The question that we must ask ourselves is, we are offering these programs, our members are attending these programs, but the question is, why are we still seeing a lot of members committing suicides? Why are we still seeing members being medically boarded due to PTSD? So these are the questions that must come from the commissions. We need to assess, the quality of the programs that we are giving and the people that are attending these programs. The colleagues that commit suicide are the colleagues that will have seen a psychologist or not. So these are the questions that must come, and we must also be able to provide some answers in the commissions. Then sick leave utilization, we saw it decreasing by 12.2%, 2.4%, and incapacity leave, 433,475 days were taken, and all submitted medical certificates. And the common illnesses is the psychiatric and behavioral, 25.1%, and the 19.5% is musculoskeletal. Hey, this one, I know Netengwe can say it. Yeah, Netengwe. Then acute medical, which is 19.2%. And prevalent conditions is mental health, again, neurological, which is 26%. And again, that Netengwe will repeat it. Then disease patterns is lifestyle, cardiac, renal, neurological conditions. The doctors will pronounce this. I'm not a doctor and I don't want to be a doctor. So sick leave rates, SAPS maintains a lower rate of 3.22% compared to the global benchmark of 4.6%, 4 to 6%. Then in terms of the interventions, the EHW proactive interventions, awareness programs, participation increased from 33.13% to 45.45%, and religious devotions also increased from 6,927 to 12,357, and health and religious events also increased from 562 to 1,370. So we are starting to see our EHW interventions being attended by our members. Counseling and support that was provided, now we are talking reactive interventions, 12.22% received support during the financial year 23-24, and trauma debriefing, a slight decrease to 1.87%, and bereavement aftercare, 907 visits were conducted, and wellness screenings, 28,697, and employees across 1,611 sites. Here we are working together with our medical aid scheme. And the utilization rate, SAPS average utilization rate is 39%, exceeding the global benchmark of 3 to 5%. In terms of the achievements, workforce stability, We have successfully maintained our staff complement at over 100% of the establishment, as I've initially indicated. And we also managed to strengthen the Directorate for Priority Crime Investigation, where we gave them additional 146 law graduates, and also the post-promotions, which were timely concluded in the financial year 23-24, where we promoted 2,069 employees. These are supervisory positions that I mentioned. And from April 24 to 31st of January 25, we also again advertised 3521 posts for post-promotions, and they were filled. And we also advertised some senior management positions. And again, 186 posts were advertised. They are still under consideration. And we are also busy with the filling of the 40 posts in the senior management level, including the 2 posts of the provincial commissioners. And 325 posts on level 2 to 12 were advertised. I think when it comes to supervisory position, I must say we do not have a problem, because we use the money that was there. We always make sure that we advertise those vacancies. The problem is bringing more boots on the ground, getting our production core. Then over the past 3 financial years, we have successfully enlisted a total of 28,252 new entry-level police trainees. I've already alluded to it in my earlier slides. Yes, we are having some challenges, and we all know that budget is always a challenge. And we experienced a holdover of 860 million from the 23-24 to 24-25 financial year. And this was as a result of receiving a reduced amount for improvement of service benefits for SAPS employees during 23-24 financial year. Then in terms of our priorities, enlistment of police trainees, this is happening continuously, but in the new financial year, as I've indicated, we are going to see a reduction from 10,000 to 5,500, and we are also focusing on capacitation of the detectives. We gave them 4,000 for previous financial year, because we also realized that the detectives need more people, and we are also assisting DPCI in terms of making sure that they have enough capacity, as well as the forensic analyst. The great progression of constables to sergeants and sergeants to warrant officers, the implementation of Agreement 2 of 2018 is still a problem, and is something that we really need to discuss. Especially, there will be a commission that will be focusing on, and I'm sure you heard also some of the colleagues that were giving us their inputs. They indicated that a constable will remain in a rank for 12 years or 15 years without being promoted. These are some of the things that we really need to focus on. And again, as I've said, we'll be filling all the critical supervisory position. Basically, colleagues, that is the as-is picture of the division human resource management, or of the human resource management in the organization. And as we'll be going into commissions, I want you to have this information, or to take this information to guide your discussions. And we want your wisdom. We want to tap on your wisdom to change the as-is to a more improved situation for the benefit of the police officers.
Thank you very much to the DNC, Acting DNC for Support Services, and also the Divisional Commissioner, Human Resource Management, Lieutenant General Nkua. I think General will agree that we have now mapped out the as-is. What we've listened to is a picture of what is currently being done. And if we link it to what the Minister said, that what we are currently doing is what has brought us to this point. And we have seen that there's a need for us to optimize what we're doing, to improve what we are doing. And there's always the issue of financial resources being the greatest challenge. Now, where there's a point, and I think this is for the commissions, where there's a point of financial resources, it must not become the end of the road. It must be a point or a juncture where we innovate and look at other means and ways of trying to resolve some of the challenges that we are facing. Now, I think, General, we've seen the departure of the Minister. He had an urgent engagement to take care of. So we're going to adjust the program slightly so that we cover the issues of today. So you'll see in your program that today we are covering many presentations from various stakeholders, so it provides a proper context to this workshop. So tomorrow you'll have a better idea and it will then inform you a bit better on how we will deliberate in our commissions from tomorrow. So at this point, I think we will adjourn. We will adjourn the meeting for 30 minutes, and we will do tea. We shall return promptly at 11:15. Are we okay? 11:15, and then we will take presentations. May I request that we allow, please, sorry. Okay, before I say that, there are some, okay, let me try this. Okay, this is better. Can you hear me? Can you hear me on this one? No. This one? Okay. I was told again, somebody whispered to me that there's some people, I'm not sure if you're members of the SAPS or private members, that are attending another meeting with the municipality. You are sitting here. You also run the risk of being arrested in here. You're at the wrong venue. Please, at this opportune moment, I think you need to find yourself at another venue, because here we're talking about serious security issues. Let me allow General Nkua to leave the auditorium. Let's stand, please. And we're back here at 11:15. Thank you very much. Just outside for you. Can we put up the presentation, please?
Good morning, colleagues. Okay. I was asked to, initially was say, talk about the trends. I said, hey, if I tell you how the public service look like, it might not be nice or it might not be good. I said, but I will give you the overview, how are we supposed to reform the wellness program in the SAPS based on what the model that we're using as the public service. That's how it looks like, the first presentation. The next slide. Next slide. Thank you. So this is the model that we use in the public service. And actually, we have realized that majority of the public servant, they don't know that we do have a wellness program in government. Only managers and the practitioners, they are the one who are aware. And then the practitioners are supposed to service their employees in their department. So this is evidenced by one of the conference that I've attended. So one doctor from Department of Health, and then she was presenting, she said, there is no wellness in government. I'm the psychiatric doctor, but I can tell you there's no wellness in government. Then I realized that it is in the website. Our framework, it is in the website. This was I'm presenting, it is in the website. So I'm not quite sure where is the problem. Now, the framework, it have got 4 programs or policies, which it have been developed in 2008, so it's long, in 2008. And then it was reviewed in 2012. It was also reviewed in 2016. We review it in 2019. The last time we review it is 2023. So we review this framework in line with the latest development and also the National Strategic Framework for HIV, STI, and TB, and other framework that we have in government. So these frameworks, if you look at there, we have got the HIV, STI, TB management policy or program. It is in line with the NSP. So what we do, what all the sectors are doing, and then we contribute into the SANAC. Then we give the reflections of what is happening within the space of government. And then into the next one, we have got the management wellness policy. This is where we deal about the psychosocial. I think when you talk about your stress, your depressions, and all other things, your financial wellness, I hear that the generals was given an example with the suit. So we do also educate our employees about the financial wellness, knowing very well that we pays you well. And then when we pay you so much well, then we have realized there is a problem of utilizations of the money that we give you. And then that's why you will end up going to Abu Mashonisa. You are not going there because we don't pay you. You are going there because of probably lack of knowledge how to utilize the money that we give you. On top of that, we give you the benefits. We give you the housing allowance. We give you the allowance for medical aid. And then when we do a study, we found that what we pay in government is a little bit higher than what the private sector are giving. It depends about the sectors. And then we do have the shack management policy. In that policies, we talk much about taking care of yourself in the workplace in terms of the risk, the injuries, and all those things. And then in that case, when you get injured, I think you all know that the quota kicks in. And then it shall actually make sure that all your health, occupational injuries, and occupational diseases, they are taken care according to the quota policy. And then it takes you until you expire in life. And then the last policy is the health and productivity management. This one, it's more where we integrate it with the pillar, the policy on ill health retirement. That is, I call this as a tertiary management, because when we say to you, from the HIV, we said, okay, take care of yourself, and then you happen to be infected, either in the workplace or out of the workplace. We don't actually take anybody out of work. Now, in that case, then you have to go continuously taking your chronic illnesses. That's where you fall into the health and productivity. The same apply when we talk about the wellness. When we say when you take care of yourself, exercise, eat well, and then if we go outside and then you dish up your plate, you find that it is bigger than the Table Mountain. It is not our issue. Then you are going to develop hypertension, you will develop some diabetic mellitus and other hyperlipidemia, all those health risk diseases. So when you could not maintain at the wellness program, then we put you into the HPM. We say because now you are living with the conditions, you need to take the treatment. Sometimes it may interfere with your production. Therefore, we need to look reasonable accommodations where we can put you in. So that is the tertiary management program. When you have failed with the 3, then we put you there. And then if you fail with that one, the next step is to assist you, and then we take you to the Langbo. You don't know what is a Langbo? It's a cemetery. Now, I've put this general timber deliberately, this Adams theory. The Adams theory, it's an enabler to assist us to implement the program, the EHW program in the workplace. What does the Adams theory talks? It's about the balance between the input and the output. Now, there is an expectation when we appoint you in government as you become police officers. The expectation is that you are going to do or render or assist the departments to meet its mandate. Therefore, your input, it's your qualification, it's when you do your work, the work that you are doing, everything that is expected from you is the input. And then this Adam theory, it talks about 2 things. It talks about people are motivated by what they put in the workplace. And at the end of the day, they expect their output to be recognized. And then when we recognize your output as the employer, we recognize it by compensating you in terms of monetary and in terms of all the benefits. But as government, we have realized that as we keep on compensating you as the output, sometimes we make mistake. Because now there is no longer the balance between the input and the output. And one of the mistakes is the PMDS program. That when managers, they're supposed to acknowledge the output, the input that has been given by the employees, then there is no that balanced. And then the employees, they tend to bring more grievances. And then since we stopped the PMDS, as DPSA, we have got less grievances related to PMDS. So now the problem, it is not with the PMDS. The problem is with the implementer. Regardless that how much we can teach you, but there is that discrepancy whereby we get a lot of grievances related to the PMDS. And also, the Adams talks about, it shows the employer that they seek balance, they compare. What I'm doing, if I compare it with my other colleagues, are we recognized equally? Then if these recognitions, it is not being recognized equally, the other we are doing the same job, we have got the same qualifications, we have got the same output, but when coming to the recognitions, it is not balanced. Then it creates an imbalance. Now, when it creates an imbalance, then there shall be unconducive work environment. There will be fighting in the workplace, like the relationship between the manager and the employees is no longer in a good space. Then we will see this by the grievances. And then now it needs us now to come into the work-life balance. One of the objectives of the wellness programs. How do we make sure that we capacitate this manager? Because the powers that the employee have is to lodge a grievance if they are not well treated. And the powers that the manager have is to discipline if the employee, it is not performing according to the expectations as the employer. Then they must have that balance. So now as the wellness program, we need to be able to put this Adams equity world. And then I put it deliberately because I'm aware that General Temba, you have got so much educated wellness officials in your unit. And then they will be able actually to put it into, to operationalize this, whereby you're going to have a supervisory training to all the managers so that there must be a balance. Whatever the employees, they are inputting it, then whatever we are output to give it to them, there must be a balance of what they are putting in, it's what they are getting out. But also we are able to see it that we are not doing well, because we will see it by the citizen when they strike against us. Poor service delivery and all other things. In the police station, we'll see people probably sometimes they will come and complain that there is no enough response. There is a one vent that is serving more community. So the balance, it is not. The input, it must be equally to the output. We give enough resources to our officers, and then we service our citizens so that we will have minimum protest based on what we are being expected. The next slide. One of the reasons, again, we're trying to professionalize the wellness program. In the SAPS, you don't have the problems because I just said you are more educated. But yes, there are other departments whereby when you're supposed to have a professional EAP practitioner, EHW practitioner, if that particular person was a teacher, and then in his career, he probably do a module in psychology. And then once he have done that module, he regard himself as a wellness practitioner. And also you will get the other associations which they are, I think there was a time that I was presenting in IAPA. I think it was in Stellenbosch. Then after I've done my presentations, how the wellness program in government, then Professor Terry Blanche, then he came to me and said, no, Robert, now I understand what we are producing as the university, because he used to have a 1-week program for the EAP. And then when people, they go to that 1-week program for EAP, they get a certificate. Then they use it to apply as the wellness practitioner. And the departments, they recognize that one week. I'm not quite sure what NQ level was. So I'm not quite sure in terms of the credits and then the norms. So, but after I've talked about this, the professionalizations of the wellness program, what we are doing in government, he said to me that I'm stopping that program, and he did. He stopped that program because what he was producing, it was not adding value in government. And then those employees who went to do 1 week, when there is an advert, they put it, they say, no, but I've got a wellness program certificate. So now the problem that we have today is those people who are in the system. And then another reason that we got it is if you are an employee, you are not doing well in what you have been appointed. You have been shifted to the wellness program. So already you are a problem. Psychologically, you are not well. How are you going to take care for the well-being of the employees? So these are the challenges that we are moving on. We have changed it. We have put it into the framework, the requirements, and then we are using all the requirements in line with our occupational dictionary. And then we look what the university are producing. So we are moving towards that direction. And I'm saying those who are in the system, we can't dismiss them because you know it's not easy to dismiss anybody in government. So now their functions will be limited to HR, not psychosocial. Because you have got somebody who say he's a EHW coordinator. You have got somebody who say he's a EHW practitioner. So there is a difference. A coordinator is like a post office. You are going to hire the ICAs and other service providers to come and provide the wellness for you. So what you do, you take the report. And then sometimes they become not so wise. They will allow ICAs or any other service provider to go and present this report into their EXCO. So if we were going to retrench people, you will be the first one. Because you are not adding any value. You are just a post office. So that I advise them to say, don't allow anybody to come and present your work to EXCO. So that you must be seen as you are doing well. And then make sure that you understand the language. But don't touch our employees. And you say you want to provide psychosocial therapy. So that's what we are doing. And then the SAPS, they don't have a problem with that one. So we have a problem with government for those people. And then one of the issues, I've seen it in the biggest employers. The biggest employers in government is education, it's health, and SAP. So some within these three they are coordinators, they are HR people, and then they are the biggest employer. And when we look into the report for the GEMS report and we look into the health risk assessor, you have got the top 5 illnesses, which is mental health, HIV, hypertension, hyperlipidemia, and diabetic mellitus. So when you're supposed to go and use the HPM program, the health and product management, how do you capacitate these patients to live with the condition and become productive? They don't understand. So it's an issue. The next slide. Then whatever we do in government, we must record it. We must report it. And another way to understand the reporting mechanism, to tell you, assisting our minister, if anybody in parliament, they want to know how sick is the public service, I'm able to pick up this report because I know that each department in government, they must submit their operational plan by the 31st of March. Then I'm able to know what they are planning to do. And then by the 31st of May, they submit the annual report. It is the report that tells me that what you have committed to yourself, have you done it? And then we have got another one that we call it a system monitoring tool. This tool, it is about assessing the level of implementations of the program, the wellness program in government. So I'm able also, when they submit it, to check it. Then we are able to say Department A and B and C, they are not doing well based on this report. We as DPSA, we do things that we call it targeted support. So targeted support, it is informed by these reporting tools to us. Then we go to that department. So we have seen you that you have committed yourself that you will do screening. And then when we look your report, you have not done it, and looking into the populations that you have got so many employees. We have got hypertension, diabetes mellitus, hyperlipidemia, HIV, and mental illness. What programs are you bringing to provide this, to provide the intervention? So when we see that, then we come, and then we do an audit, and we sit down with you. We need the chief director of HR, we need the wellness people, we need the leave management people, so that all these report, they must inform the practitioner what types of programs do you need to do in response to the current situations of your departments. That's how we implement our programs. The next slide. I think these are just the interventions that I just told you right now. The next one. Thank you very much.
Did we enjoy that presentation? Come, you can give him another clap then. As we know that in the South African Police Service we have two streams, right? You know the two streams? The one is the Police Service Act and the Public Service Act. And we know members of the Police Service Act, we are members of PaulMed, and our members of Public Service Act are with GEMS, right? So we're very pleased today to have with us the head of clinical services from PaulMed. So now we're talking to the members appointed in terms of the Police Act to speak to us, Dr. Majatladi. Please give a round of applause.
Thank you very much, Program Director. Good morning to the Deputy National Commissioner, Provincial Commissioners in attendance, General Temba, all senior officials of SAPS, all SAPS members, the PaulMed Principal Officer, Ms. Neo Gawe, all stakeholders and all speakers for today's program, all protocol observed. Dumelang, I am Dr. Malebo Majatladi. I'm from PaulMed. As the program director has indicated, I am in the clinical services unit. We can move on to the next slide, please. As the program director has touched on, PaulMed was established as a fund to ensure that we are able to financially support the healthcare needs of members of the South African Police Services. And the establishment of PaulMed is under the South African Police Act, number 68 of 1995. We as a scheme are a non-profit organization. We are a restricted scheme, meaning that we only cater for SAPS members in comparison to other schemes out there in the market that will take any member of the public and assist them. The purpose of PaulMed is to ensure that we provide quality health care to SAPS members and their dependents, and that we ensure that we do it in a cost-effective manner. From a strategic perspective, the PaulMed board has formulated a strategy that sits on three key pillars. The first being scheme sustainability, to enable us to fund the healthcare needs of our members. We need to ensure that the scheme is in a good financial position. And the second pillar is that we provide quality health care for scheme beneficiaries. And the last pillar being sound relationships with stakeholders. And in the PaulMed world, we always say that the PaulMed members are the VVIPs in our world, and all other stakeholders come second to our members. From a demographic perspective, which is where I want us to start, to contextualize SAPS membership base, I'm going to take you either through 5 or 3 year overviews of where we are as a scheme. We are sitting at an average population right now just under 500,000, and that has been just about the range that we've been fluctuating at. Right now, our average age as a scheme is 31 years of age. Our pensioner ratio, those members that once they go into retirement, we call them our continuation members, they account for 6% of our population. From a termination perspective, we again have remained under 1% through the years. But what I want us to really focus on is the graph underneath at the bottom of the screen. And that is looking at the morbidity, which is the overall wellness and health of PaulMed. Over the past 5 years, you will see that there is a steady incremental increase as to the population morbidity. And that basically means that our members are becoming ill. Over the 5 years, this is a steady pattern that we've seen, and if anything, in 2023, through some of the interventions that we've introduced at PaulMed, we are now starting to see a turn in the tide. But one thing that is for sure is that non-communicable diseases, the chronic diseases that have been spoken of, are a major ongoing concern in the PaulMed space. Thank you. Next slide. We have been able to dissect our data to demonstrate which age groups and in which province are we having the biggest concern. On the left side of the screen, or on your right side, we looked at the gender split. We understand that females have earlier onset of health-seeking behavior, and that is a constant through the various age groups that we have in PaulMed. However, male members are not seeking healthcare services up until the age of 40. So to the gentlemen in the crowd, we really do advocate for the male members on PaulMed to start engaging with the healthcare services that we provide from as soon as they join SAPS, as soon as they join PaulMed. In 2023, what we were able to identify that in the Western Cape, in the Northwest, and in the Eastern Cape, for men in the age group of 22 to 31, we had an adverse claim pattern year on year in terms of what we were paying for them accessing care. This tells us that the members were actually having more trauma-based access to care requirements during that point. Because you'll see in 2024, we reverted right back down to men having a far lower healthcare access need compared to females. So apart from the episodic events where males in that very young age group of 22 to 31 years seeking care for very trauma-based events, they are actually not getting care. With men in the age group 40 and above, they are actually the cohort or the group of members that have, one, the biggest profile of chronic disease, but two, that actually cost us the most to manage their chronic conditions. We can move on to the next slide. At a provincial level, Gauteng actually accounts for the biggest proportion of our total costs. And this is very much aligned to the distribution of our membership as a scheme. After Gauteng, we then have KZN and then the Western Cape. The 27.8% proportion that we spend in Gauteng is going to show a very different picture in the slide that is to follow. We can move on to the next slide. I've demonstrated to you that Gauteng, KZN, then Western Cape. This slide speaks to how much we are spending as PaulMed per life. So each individual, on average, how much are we paying for them in the various provinces? What we have picked up is that the Free State is actually the province that has the highest cost per life per month. And we will explain and unpack that because We don't anticipate this picture, but nonetheless, it is a reality, because after that, we then have Gauteng as the second highest in terms of cost per life per month in terms of medical and surgical care. Thank you so much. Moving on to our chronic disease profile. The scheme right now sits on close to a quarter of the scheme beneficiaries having a diagnosed chronic condition. We're sitting at 23.7%. However, if we are to look at just the main members on PaulMed, which is the SAPS members that sit before us, we are actually reaching 41% of SAPS members on PaulMed have a diagnosed chronic condition. So that already speaks to the magnitude of the health burden that SAPS has in their environment. From the age of 34 to 44, that is when we start to see that substantial increase in members having a diagnosed condition. Normally, you would expect members to start having chronic conditions in their 40s, in their 50s. But in the SAPS environment, we are actually starting to see that picture emerge at a far younger age, at the age of 35. And that in itself brings about a concern as to the productivity of those members, the presenteeism of those members, and also the members being able to stay in the SAPS world and not have medical boarding as an option based on their disease progression. We can move on to the next slide. On this slide, what I wanted to demonstrate is that we have, of the PaulMed population, 76% of them, right? Right now we're saying, and this is across including beneficiaries, do not have a condition. But we are only spending 39% of our budget on those lives that do not have a chronic condition. However, the minute the member has one chronic condition, you will see that the cost per month that we're actually having to spend on providing care to that member triples. A member that has one chronic condition, we spend just over 3,000 Rand per month. A member that has no chronic conditions, we're spending just a little bit over 1,000 Rand. So it is very important that we proactively are able to identify members that have any condition, chronic, and also to enroll them in our programs as soon as possible, because when we identify members later on in their disease progression, we actually spend far more than this average cost that we're looking at. We can move on to the next slide. There's been discussion about the top 5 chronic conditions. In PaulMed, hypertension, we have 75,000 members with a diagnosis of hypertension, right? And this picture is very much in keeping with the private and public health sector in South Africa. Hypertension is the #1 chronic condition across private and public. The next condition we have is hyperlipidemia, then diabetes. We have included depression in this basket right now. As PaulMed, mental health conditions as a basket overall, we are out of kilt with the rest of the industry in terms of our health burden with regards to mental health. We are a leader in that space, and this is obviously as a result of the work and conditions that SAPS members do perform, but we will unpack depression as a condition in itself. What I wanted to highlight here is that depression might sit as our 4th highest chronic condition in terms of individuals with the diagnosis. But when you look at the gray bar, which speaks to the cost, you'll see that we actually pay more for depression than for hypertension. We pay more for depression than we pay for diabetes. So that in itself speaks to how members are accessing care. Our members, when they have a mental health diagnosis, They do not utilize out-of-hospital services to engage with the social worker, the psychologist, the psychiatrist. There is a preference in the SAPS environment for our members to go to hospitals as the first port of call when they have any mental health condition. And that is in part why we have the type of expenditure that we have just on depression alone. We will unpack some of the mental health. We can move on to the next slide. This slide is going to show you year on year what is the increase that we're having. Again, going back to mental health. From 2023, we were sitting with just over 23,000 lives with a chronic condition. 2024, we were sitting with nearly 34,000 lives. That is a 42.5% increase year on year on mental health individuals with that diagnosis. Second to that would be the hyperlipidemia, which speaks to lifestyle, how our members eating, how our members exercising, how they're keeping active, etc. But for me, the key focus here is that mental health is a very big challenge in the SAPS environment. We can move on to the next slide. Here, I wanted to demonstrate to the audience that we actually are sitting with an increase in the number of members that are having multiple chronic conditions. So the second grouping would show that 25.7%, this is in 2024, have one risk factor or one chronic condition. 27% of our members have two chronic conditions. And then we see 19% have three risk factors and then 4. We actually have some members sitting with 5 chronic conditions. So a member will have hypertension, hyperlipidemia, be diabetic, then they'll have asthma, then they'll also maybe have osteoarthritis for good measure. If they're smoking, then they might have asthma or COPD. But we have members that we sit and we're counting on 2 hands, and then we'll throw in HIV as well. We have members like that. And at times I sit and I go, with a member that has as many chronic conditions as we're seeing, how are they able to sit at work, take their medication, be productive, be able to go and see their doctor based on their appointments, etc., etc. It's a challenge. It's a challenge, and I think in the video clip we saw today, there was a lot of discussion about members are dealing with stress. This is another compounder to what we're seeing here. At times we'll talk about non-communicable diseases being a result of our lifestyle choices. One of those elements that feeds into that is your stress. How are you managing your stress? And we're seeing it coming through in our data in this way. We can move on to the next slide. So this is mental health, where I wanted to focus on. We have 29,000 members with depression. Bipolar being the second one, just over 4,000. And then we'll have schizophrenia, and a lot of members, only 2 have anxiety. And what is key for us is that at least 20% of those members with depression are what we deem to be high risk. So these are members that, based on their mental health, they are just not able to perform activities of daily living. So they come to work, they sit at their desk, they're not able to really engage with the rest of what is happening in that police station and so forth. And this is the picture that at times when we talk about members or SAPS members not being there for the communities and this and that, community members also need to appreciate that SAPS members are sitting with a very heavy burden and duty on their shoulders. And with our support, we need to be able to turn the tide in this very growing picture, especially on the depression front. We can move on. I wanted to focus again on depression and to say that Gauteng is the province with the highest depression rate. And then after that, Western Cape, and then KZN. Right? From an age perspective, we actually have the highest peak in terms of depression in the age group 45 to 54. And when members are moving towards 55 to 64, that is the second cohort in terms of the largest profile in terms of depression. So members, as they proceed towards pension age, their depression rates also go up. So that is the reality of what we are dealing with right now. To say that one would think that perhaps depression is in a younger age group, but majority is from 45 on, and we're seeing it in our continuation members as well. And once members do go on retirement, how and what support services are there for them? Especially the members that started as part of the student intake in their 20s. I think we are embarking on student intake right now this week and next week. And they are with SAPS their whole life, their whole career life. When they hit pension age, that's when we see a lot of them coming and saying, I have depression. I don't know what to do. When I go home, I sit with my thoughts. What I saw at this crime scene, what I saw in this specific case, etc. And that is a cohort because they're not with us on a daily basis in the police stations. They're at home by themselves. How are we coming together to support them? We spoke of medication as well. One thing that we are also picking up is that our members that have mental health diagnosis are not being compliant on their medication. And in part, it is part of the spectrum and an issue of having a mental health diagnosis. But just that pharmacological intervention to assist them to come out of that space of depression. Normally with antidepressants, it would take about 6 months for a member to start seeing a positive impact. But we're sitting with only 47% of our members actually taking their medication who have an authorization for chronic medication for depression. So again, that is another struggle. And from a mental health perspective, whether it is said, whether it is implicit, there is the stigma that is carried with mental health. So members either choose not to interact and engage with healthcare services in an out-of-hospital setting because there is that stigma. As you are aware, your jobs require you to carry a gun, your jobs require you to execute certain duties. Is the stigma of me being diagnosed with a mental health condition going to impact my ability for career progression and executing my duties as a police officer? Those are the questions and points that come up when we engage with our members that have a mental health diagnosis and are scared to disclose in the workspace and to gain support from the existing structures within SAPS. Thank you. We can proceed to the next slide. I'm now going to move through the wellness space. Wellness, as PaulMed, we provide a very comprehensive wellness benefit package. One thing that we touched on initially in my slide on the cost per life was to say Free State is a concerning province for us. And this is the reason. Free State has the second lowest testing prevalence from an HRA perspective. So that means most of the members in the Free State actually do not have health risk assessments. So we're not able to identify when they have a chronic condition. They themselves don't even know. And then, coupled with the fact that they do not test, if we look at the medical admission rate per 1,000, you will see that Free State has the second highest hospital for medical admissions. So these are the non-communicable diseases. And then you also see that at the average cost, Free State has the highest again. So that for us is saying that Free State as a province, there isn't much wellness screening happening for the members in that province. But coupled with that, the members are predominantly landing up in hospital. That's their first port of interaction with healthcare services. When they go see their GP that one day, the GP says you have to get admitted. What is different, though, is that KZN as a province, their health profile is a little bit different, and I'll touch on it, because you'll see that they have the highest admission rate per 1,000 lives. And then, again, they have the highest medical admission. KZN as a province has the highest mental health disease burden out of all of the provinces in SAPS. We are having the highest hospital admissions in KZN for mental health. So as from a province perspective, these are the two provinces where we are ultimately going to have very targeted interventions, because we also appreciate that the figures that we have are figures that emanate from members that will ultimately go to the hospital, ultimately engage with a health care provider. There are members that have concerns, have medical conditions, and are not even interacting with the healthcare paradigm or spectrum. And that in itself is a concern to say, who are the individuals that we do not even know about that have these issues that are working in the SAPS environment? We can move on to the next slide. To correlate wellness again to our morbidity profile, when we look at KZN and Free State, you will see that their wellness screening prevalence, the orange lines, are fairly low. And the blue line indicates the chronic morbidity of that province. So you'll see that the lower our screening prevalences are in the provinces, Free State and KZN, the higher our morbidity profile is in these two provinces. However, we have a different picture. In Gauteng, they test more frequency there, and in Western Cape, and their morbidity profile becomes a little bit lower. So it is very key. I think this is a key slide for us to say that it is very important that SAPS members and their beneficiaries really engage in health risk assessments. I know right now the discussion will be very much aimed at main members, but one thing that we've also identified in PaulMed is that our beneficiaries, your dependents, are also not utilizing screening services. They are also having a high health morbidity profile. So for the members that are in the audience, those that are connected virtually, we really do encourage, when you go back home, to encourage your family members to go to the doctor, to go to the pharmacy and have your health risk assessment. Because as much as they do not have the same chronic profile as the SAPS members, they themselves, their pictures are also concerning and an important issue to note. We can move on to the next slide. We're going to now look at the difference between the members that are screened versus those that actually participate, and this is over a 3-year period. As I stated in the initial slide, we're close on 500,000 lives in PaulMed. But you'll see in 2024, for those that have screened, we actually only had 22,796 members have an HRA. Out of 500,000 lives, only 22,000 had an HRA. Those are very disturbing statistics for us. And especially in light of the activities that we embark on to go to police stations and have wellness weeks that are very much approved by the National Commissioner to say, please avail yourself when PaulMed is in your province to come and have an HRA. we really are wanting for us to get to a place where we can say very comfortably that 50% of SAPS members are having an HRA on an annual basis. And I'm hoping with the audience here that the message will filter through to everybody in their respective stations. We can move on from the slide. 5 minutes, okay. Let me hurry up. I've been told 5 minutes. We can skip the slide. Again, for us here, this slide again was demonstrating that KZN, for us, the admission rates, even for those that are screened and not screened, very high. And again, even in the medical admissions and the cost per life. We can move on from this. As I spoke about, we have provincial wellness weeks. In 2024, these are the provinces that we targeted. We can move on to the next slide. What I wanted to highlight on this slide is the fact that with our wellness screening at a provincial level, we are only achieving 7,000 members engaging with us as PaulMed. With our well-being activities, and this would be the police intake at Police Day, and also from the sporting events that we participate in, we are having a bigger amount of members actually engaging. We're sitting for 2024 with 13,000 lives. And we want to really encourage SAPS members to participate. As PaulMed, we are now supporting the SAPS Marathon Club, and we are expanding to other sporting codes. And in that way, we are just fostering that culture of a positive, healthy lifestyle and ensuring that we get better health outcomes as well. We can move on to the next slide. This slide is demonstrating that weight is the #1 biggest issue in SAPS. BMIs are high. Second to that is blood pressure and then cholesterol. We are also picking up that alcohol is an issue in the SAPS world. Alcohol risk. And it's not spoken about much, but it does come through in our mental health profile of our members. We can move on to the next slide. And in terms of wellness screening, as I said, 2023, we just had only 10,000 members. 2024, we set at 21. This is a 98% increase, but again, we're coming off a very low base. We have 34% of our members overweight, 21% obese, and 3.3% very obese. We have a weight loss program. So please look at your benefit guides. We are trying to craft our benefit product to talk to our members' healthcare needs. So there is an out-of-hospital-based weight management program, and we really want to encourage members to do that. Psychological debriefing services, very low utilization. Our benefit product offers individual or group debriefing services. If you want to go and see a social worker or psychologist, we have that. Please move on to the next slide. This is what we were talking about to say PaulMed is very much in support of the running club in SAPS. We have participated and supported the SAPS runners in all of these marathons in 2024, and we obviously are looking to engage in other sporting codes just to promote that health and wellness philosophy. We can move on to the next slide. Our members that are in the running club have actually 42% less claims. They have a reduced claim profile, better health state, better weight control. They also have limited chronic disease profile. So please, everybody, dust off your sneakers wherever they are in the closet, find them, put them on. I'm not saying run a 5 or 10K run, but just walk. Just walk. Thank you. And then the next slide. These are our conclusions as PaulMed. We offer comprehensive benefits, and it's not often that a scheme will say, please utilize your benefits. But I'm here pleading to say, please use your health risk assessment benefits. Go to your GP, go to your pharmacy, engage with us when we come to your province and have health risk assessments. We want you to use that benefit. The morbidity profile of PaulMed has increased post-COVID, but with managed care interventions, we're starting to see a slowdown in that picture that we have. We've spoken about mental health disease, but coupled with that, the very low utilization of funded service in the out-of-hospital settings. I haven't touched on fraud, waste, and abuse. I think everybody can read the last points, but I wanted to raise the point of fraud, waste, and abuse as a parting shot. We appreciate that members will have policies for hospital admissions. Some of our admissions for mental health is members go in there for 2-3 days, a week, into a facility, and they get paid out by their policies, the hospital plans. So there is a degree of fraud, waste, and abuse in our space, and we want PaulMed members, SAPS members, to protect their fund. Please let us not have this abnormal, fraudulent, wasteful type of healthcare accessing. Let's not buy wigs using PaulMed and shoes. But I think that is my parting shot. Thank you so much for your time, colleagues.
Peter. And what's Kanzini? They are with us already. Okay, thank you. From GEMS. Is Dr. Miller here? Oh, GEMS is here. Okay. Dr. Matsladi and Dr. Foromo, thank you very much. You may descend the stage. Now, we want to also make sure that we get a proper understanding of the offering that GEMS now have for our Public Service Act members. And we know that our Public Service Act members are equal to the task in terms of very critical functions that they perform in the South African Police Service. So we're very appreciative of all our members that are here from the public, that are part of the Public Service Act, and members that are joining us online. And I want to indicate that we have a caring leadership, not only for Police Act members that are wearing uniform, but also the support staff within the Public Service Act. So let's welcome Dr. Miller. Over to you, ma'am.
Thank you so much, Dr. Reddy. I just want to state, Deputy Commissioner said she's not a doctor, and also I'm just a civil servant. So I'm afraid of the ranks and not mentioning the right things, and where I come from, so can I please say with those words that all protocol observed? Thank you so much, Deputy Commissioner. We can fly the slides if we're ready. So this is us, GEMS. So just a little bit background. Any GEMS members in here? Yay! Okay. Because I feel a bit intimidated by PaulMed, like, yo, ish, yeah, my people here, you know? Like, yeah, it's good to see you. So with GEMS, we represent, you know, remember, GEMS, we're covering the whole country. But what's happening when we're looking at SAPS? So when it comes to individuals within SAPS that we cover, it's around about 85,000. And within that 85,000, 19.3 are registered, with chronic prevalence, and that they spend about 76.3 of the costs. However, when you're looking at that proportion, just looking at the GEMS population, it's a bit lower. So that's some good insight to see. Next slide. So this is just the care plans. Like, it's almost taking a roadmap to what do we do at GEMS. Lifestyle wellness, preventative, the same thing that PaulMed was, speaking about. We've got preventative programs, we've got lifestyle awareness, and also once the disease sets in, you're told that unfortunately you've got high blood pressure. There are chronic, ways to deal with the condition that one has. Also with acute events, being that like one gets involved in an accident and you need to move them to a certain hospital, and also how the disease, if it complicates, there's certain places. And so we look after you from the inception of taking the policy throughout all the health stages that you might go through. And as Dr. Foromo said, what's that? What was the cemetery? There was the word for the cemetery. Langboom, yeah, until you get end of life care. Next slide. So one thing that we're seeing, especially with the preventative care, this is one of the benefits that you pay for every single month, but is underutilized, be it you as the member or your beneficiaries. And this is the same across cutting all medical aid scheme. So preventative health screening is one of the most important health strategies for us to see and diagnose early on. Pick up if there is, in diabetes, you also get like pre-diabetic, and they're like, what is this, doctor? And we're like, hey, it's amper there, but it's not there. So let's try and reverse it, So we pick up certain things like that when you're going through your preventative screening. And GEMS offers a very comprehensive screening and preventative benefits to its members, but not just its members, also your beneficiaries. I see a lot of men here, and sometimes, when your woman is pregnant, they don't even know the benefits that they have because you are the one that sits with the card holder. So we're hoping that at least there'll be better engagements and that the beneficiaries also know what is it that they have because you have signed up for the medical aid. Next slide, please. So when you're looking at our preventative screening, it's quite detailed. And these are just things that are available to the members, but we're not seeing utilization. Blood pressure monitoring. Top number, bottom number, do you know what that means? I always just say the top number, it must not be more than 140. Bottom number must not be more than 90. That's all you need to remember. If you're sitting any of those numbers, it's high, then we are like sitting at high blood pressure level. So it's those small things that we try and give to our members in the screening platforms and in the wellness days. However, utilization is very low. And this doesn't necessarily need to be taken up only in screenings that are happening when we come to you. But you can go to your GP and like, hey, doc, give me a bill of health. Tell me what's going on. Zenze zonke lezi test. Kune HIV, kune pap smear, If you're a woman, of course, you can't do a pap smear as a man. But the appropriate one. So also cholesterol, mammogram, and peak flow. And also just within the HIV one, we're going to speak about a nice program that we have as GEMS where even in a sector now in the country, when you're looking at patients that we see around about December, if you're ever a doctor and you're consulting and seeing patients over December, a lot of people come with drop, a lot of people come like, ish doc, like, yeah, I want to go and pee, it's a bit difficult, and you have to handle such sensitive matters. But what's been beautiful in the country is that now we've got pre-exposure prophylaxis, meaning that you can be on ARVs, but you're not HIV positive, but it's going to be a risky time, so you just want to protect yourself, So at GEMS, we pay for that. I'm giving you the hints. So at GEMS, we've got that even in and it comes in more even for new benefits. So it's not going to be coming from day to day. Other medical aid scheme, when you do go for PrEP, they'll take it from your savings and your day to day. But this is coming from the HIV benefit, and which is also part of the whole preventative element that we're trying to push. Next slide, please. So when you're looking at these numbers, the blue is generally the GEMS population, and the orange is what's happening within SAPS. So if you see you guys are doing well with the pap smears compared to what's happening generally, up at 11.4%. However, with prostate screening, ish, Bontate, please, can you go? It's no longer the finger, it's just a test. You know, so if you can please go. It's just a blood test. I promise you. If someone does the finger, then yeah, you must call me. But we just do the bloods right now. You know, it's a small prick, but it really helps us understand what's happening, especially after the age of 40. And also when you look at glucose screening, so SAPS has done very well there. You know, it's screening a lot. However, when we look at influenza, and this is another interesting one that we're seeing a very low uptake in the scheme. So during the flu season, especially it's coming up in the next few months, not a lot of people are going for their flu vaccine shots. And this is also something that is covered. So please utilize those benefits. Next slide, please. So when we look at our disease management program, once you've been told that you do have hypertension or you do have diabetes, we want to take you through the whole journey. We want to give holistic health and make sure that you are better managed and you're well controlled. Because it's expensive for you if you're lying in hospital. So how do we best take care of you and also increase your lifespan or that of your beneficiaries? So the whole journey starts from diagnosis, also chronic program registering you. This can be done telephonically, via WhatsApp, or even just via the web. And also you've got the ongoing monitoring of our chronic medicine, disease medicine program, sorry. Also you get pharmacy allocation and counseling, you know, where it helps to decrease co-payments. Claims process, that's all taken through. So that's just the journey of how it goes. You can go through the next slide. This slide becomes very important in terms of how do we manage and coordinate care. We're very big about care coordination, so that's why even with our different platforms, you know, we've got Tanzanite One, which is our flagship, and it really supports the people on the ground because we support even umuntu oseqoqodala who does not even know what medical aid is, but yet angaya nge GEMS card yakhe ukuba ndizongena eSt. Dominic's. You know, I'm not you know, brands, but it's just to show from the highest paid member to the lowest paid member, we are representing what actually happens within South Africa. So it's important for us that in that center, you've got the member, you've got the person that's sick, be it even it's the beneficiary. And how do we best coordinate care and also to support them? Because at the end of the day, as doctors, as health providers, we can talk all what we want about health, but the custodian of your health is you. So that is where it's shifting, that empower you so that you can take care of your health and know the benefits that are available to you and your beneficiaries. Next slide. So with our disease management programs, we've got a couple, and they run very well for the people that are already on the program. Remember, we said that the whole idea is to prevent you from being sick. But once you are sick, we're like, okay, let's keep you here and try and monitor you so that you don't end up with adverse effects. So we've got a chronic medicine management, oncology as well, especially because at that time, most of our patients are needing expensive drug. There's just a whole lot that goes on the oncology program. Renal dialysis program. We know there are a lot of people that need dialysis almost 3 times a week. Maternity program, which I'm very much passionate about, and hence with the gentleman, if your lady's pregnant, tell them to sign up, because we have ladies that don't even know they have that, but they're a beneficiary. The husband is the one that's the main member, but doesn't know a maternity program at GEMS. So it's that type of knowledge that we need to instill. This one is also very nice, in the chronic back and neck rehabilitation program. With all that we saw with PaulMed, especially the musculoskeletal, the musculoskeletal issues, that's where the chronic back and neck rehabilitation program comes in, because it assists, especially with the type of work that, you know, SAPS members ends up doing, even if, you know, in our mandated GEMS, we're not supporting the front line that are going out there. HIV management program, this is also quite beautiful, especially in a country like ours. Even if Trump wants to take his money, we will still be fine with the HIV. So just a quick one. I'm getting an eye from Dr. Reddy. I hope I still have a bit of time. So just when it comes to what we're seeing for the average GEMS population and with the SAPS, it's the same numbers. Hypertension is sitting high up there. Still, those numbers, 140 top, bottom number, 90. If any of those are high, then you've got high blood pressure. We can take it offline to educate more, but it's very important that, can you please go back to the previous slide? I just want to show that mental health also comes up. So if you see, it's hypertension, diabetes, so those are the top drivers, and also depression is there. So it's a very similar picture to what's happening at PaulMed. We did not copy. You must just ask Dr. Malklaj. We did as copy sananga, so it's different exams. Next slide. When it comes to the compliance, and this is where our disease management programs become very important, because now we're able to see who's taking their meds, who's not taking their meds. You can see this is data for the last three years, 2022, 2023, and 2024. You can see that SAPS members are doing relatively well when it comes to hypertension. However, you know, the general GEMS population overtook them in 2024. However, a worrying trend is the diabetes. So with diabetes, you end up getting complications later on. And that has dropped from 83% in 2022 for SAPS members to 82.9%. So this is something that we really need to watch carefully what's happening, because it's going to have adverse effects for the scheme later on. Next slide. This is just the same also with mental health. You can see it's quite high up compared to what you see with the general population. So we can say there is definitely something going on with mental health within the SAPS population. So what is it that we are going to do? And hence the task force and what the minister was saying earlier on. What does it mean for the person who wants to end their life? What are we doing at the end of the day? And also asthma is another interesting one that we're seeing. So elements of smoking with the people that are with the members that are in the unit of SAPS, what is going on there in that regard? Next slide. So when you're looking at overall mental health, and these are the mental health care plan utilization rate within the scheme, SAPS is sitting at 45.9, so just a bit lower than what is happening overall at GEMS. But you can see we have got 5,283 care plans, that are available. And the member utilization is only 2,426. Next slide. So admissions rates, Doc spoke about how people go sleep so that they can get their 2.5, 3,000 rand. We also see that, another 3 days here, 3 days skip a month, another 3 days. You find that in a month, like this person, this is an extra income for you. You've got a 9,000 that's chilling, that's coming in. And the biggest high amount of hospital admissions is severe depression. This can be without psychotic symptoms. So depression. Then you've got, gastro is an easy one like that, especially for the people that we're seeing with the fraud, waste, and abuse element. Hypertension is another one, and also respiratory tract infections. So that's what you're seeing, especially within the SAPS rate. So if you see, in 2023, 715 people got admitted for depressive episodes within SAPS. Next slide. So I think this is a key slide for me to know that there is an increase in mental health admissions. So awareness and early detection and screening is very key. So, it cuts across genders, it cuts across benefit options, even if you're on the lowest to Tanzanite 1 to the highest to Onyx, it's all Gafana, same WhatsApp group, across provinces, across age gaps, across durations, and it's regardless of chronicity. Next slide. However, you should not suffer in silence, and I think this is one of the reasons why here. When you're looking at just South Africa, because remember, we're looking at the whole country, unemployment becomes one of the biggest things that leads to mental health. However, we're dealing with people that are employed now. But poor work-life balance, earlier on it was so nice to see the video of, the members on the ground saying that there's no work-life balance. It's something that is coming up, even especially when we talk about mental health. Domestic personal issues, talking finance, talking GBV. The minister mentioned even cases where, you'll kill your spouse. And I personally had a very close friend of mine who her stepdad shot him, the mother, and the siblings back in 2014. So whenever I am relating to SAPS, like I am still so much scarred by what happened, and also the programs that are being placed so that no family has to go through that again. Next slide. When you're looking at mental health, so these are the early warning symptoms. If you can, please take a picture. You can circulate it to the people around you. Just from sleep changes, the mood changes, especially for managers. If you know that your person is generally not like this, then there's something up. You can also just be able to reach out even with employee health and wellness. People being withdrawn, dropping in functionality. Doc also mentioned that. We are a unit. This is SAPS. We're here. We are the men in blue, or we're the guys at the back supporting, and we're supposed to be seen as a family. Changes in the work environment. They spoke about how, like, you know, some of the members have to move around, unusual behavior, and also just nervousness that surrounds or is way above than what is supposed to be. Next slide. So when we look at, even with mental health, the whole idea is to stick with preventative. Within the preventative element, we've got wellness and lifestyle choices, and also the psychological well-being and the psychologists that are available, and member education. However, even if when you get to diagnosis, we've got the chronic, medicine registration and also the management program. And it's important that members do sign up for those, because then there's a bit better monitoring and to see if people are compliant, as also Doc mentioned that we see a lot of non-compliance when it comes to mental health issues. And it could be an element of stigma. And at the end of this workshop, how do we make it okay to be not okay? You know, Siya Kolisi, I think there was a video going around about him saying it's okay to not be okay. So getting those figures, people that are talking about their issues and making it okay not to be okay. Next slide. So this is a light just speaking to the whole element of mental health. I think like we have spoken about it exhaustively, but depression, that's the highest we're seeing. In terms of the demographics, you're seeing more females. So within the top 4, you can see that depression was there, and around about 2,215 females were said to be depressed within SAPS on treatment for depression, and 695. And the question is, when we're looking at the demographics of actually the nature of SAPS, it was sitting at 46, it was not 50-50, I think it was 46 something, it's not 50, 54. So the question is, are the gentlemen not depressed in SAPS? Or are we not able to get it out? So I would like to find out that study. If we've got almost that 50-50 and we've got 2,200 ladies saying that actually we need help, what's going on with the men? Next slide. This is our care plan. So a care plan is just a way of assisting, especially, let's say, with mental disorders, where you've got coverage, you've got doctors that are able to see you, and there's just better psychotherapy, there's a psychologist. So there's a whole team that is looking after your care and clinical support. Next slide. Yes. I'm almost done. I try to be on time. And this is a very important slide. I think, when it comes to HIV within the country, yes, I mentioned a little bit that we'll still be okay without Trump's funding. But it's really important to not just look at HIV by treating only the people that have HIV. I spoke about pre-exposure prophylaxis. And with the amount of cases that, life happens when you want to let your hair down and you do go that one night stand, at least be on the protected side with the pre-exposure prophylaxis. That's all that I'm asking. Because yenzeka, kodwa zazi safe, safety, ube safety. So the whole HIV disease management program looks at the people that are on ARV treatments and also looking post-exposure, like doc, something happened with the last 72 hours, what can we do? Then, you sorted there. But also the biggest biggest one, pre-exposure, especially if you're at a phase of leading a risky lifestyle. And also prevention of mother to child. When we speak about that maternity program, please make sure. And these medications, I mean, everything is seamless from you getting the test done to getting the medication delivered to your office or home, depending what's going on. Next slide. So when we just look at mental health care trends, this is just to show that, out of every, when you look at the trends, it's gone higher, and this was data from 2019 to 2024. The biggest thing to take out of the slide is that 1 in every 20 beneficiaries suffer from depression, and that is something that is quite important for us to take home. Next slide. And of those that suffer from depression, 1 in every 79 beneficiaries gets admitted. And once you get admitted, it's expensive for me as a scheme. So how do we assist before getting to the depressive phase, or to make sure that people are well managed within their depression, that they don't get admitted? Next slide. So what has happened in 2024 amongst beneficiaries that are affiliated with SAPS, we've done about 8,800 psychologist consultations, 900 registered counselor consultations, and also 6,200 social worker consultations. And it's very important to talk about social workers in the context of South Africa, because you will not get a psychologist, but you'll probably find a social worker. So how do we use even our healthcare professionals that are out there to assist us in mental health, and not just only stick to a certain professional? Next. Also, 8,100 general practitioner consults were done specifically for mental health, and also 3,300 psychiatrist visits. Next slide. So I think it's just important to note that, depression is big, and it's treated by the fund from your risk benefits, so not from day to day, even including the medication that goes with it. Because I know earlier on someone spoke about medication and generics, So coordinated care becomes a very important one, and we work on making the case, to make sure that the care is coordinated. I'm worried about time now. Next slide. So just in closing, it's very important that members become aware. Please tell your beneficiaries as well, because at times, you might not be needing the services, but your daughter might just be going through something at school and needs a reach out. And also, it's important that you use your preventative screening benefits that are there. Go for that pap smear. Go for that prostate. I promise you, it's not the finger, but the blood test. Also, the high rate of admissions, if you can see how we can reduce this, and also be compliant with your medication. And also that, please just make sure you take your meds. And I think that's it. Next slide. I think that's it. This is just closing lifestyle, the stuff that we've spoken about, and also just member awareness, and also that our chronic care plans are there to make sure that life is better for you. Thank you.
So let's make an assumption, General, that there are only 2 general practitioners left on this earth. Dr. Mila, and Dr. Majesladi. Who will go for Dr. Pila to be your GP? Come on, let's hear. Clap, clap. Let's clap. She's like the cool GP, right? Dr. Majesladi is such a strict doctor. How many of you will go to a... Yeah, General, I think we have 2 good medical officers that are taking care of our members. Come, let's give them a good round of applause. Thank you very much. We're gonna do one more presentation. I can hear your tummies from here. So some of you need to take medication. So not some of you, all of us need to take medication. Let's put it like that. When you see a lot of badges on our shoulder, you just know that we are old, We are on, what is it now, preventative or maintenance or something like that. We're in one of those stages, right? All of us that need to take our meds. I just got a WhatsApp from my wife to say, please take your medication. So we're very privileged to have in our midst Mr. Manzini. He is going to talk to us regarding organizational health risks. And he's always a nice guy to listen to. He's an interesting guy. So let me invite him. He's from Metropolitan Health. Thank you very much.
Good afternoon, colleagues. How are you? Good, good. I know I'm standing between you and lunch, so I'll try and be very concise and and hit to the point so that I don't lose you during the presentation. Can I check, is the presentation ready? Is it loaded at the back? Can you please flight it for us? But before I start with the presentation, I'm going to ask a few questions. And the reason of asking those two questions are to test whether if I'm talking to the right audience. The first question is, by show of hands, or anyone who can respond, please assist. How sick is SAPS? Okay, very sick. So what is very sick? Is very sick this, or very sick that, or very sick that? Oh, wow. So if the minister asked you that question because you need to respond to a portfolio committee question, what number are you going to give the minister in terms of level of sickness? Because minister cannot say, we are this sick. How are you going to measure that? Interesting. Okay. The second question I want to test and ask is, how many of us in this room have once lost weight, reached our target, celebrated, and regain the same weight again? Aha, now I'm talking to the right people. And then the last question I want to check, how many of us believe in the statistic that through the EHW and the entire employee support programs that you have in SAPS, you can reach up to 50% engagement levels? Only one hand. Currently sitting at an average of 15 to 25%. How many believe you can get to 50%? None of you believe. Okay, I'm glad now I'm speaking to the right people because I'm going to share some of the insights and share with you some of the solutions that would help you realize how possible it is to reach more members and gain greater engagement in the program. Can I check, Dr. Tlaele, is my presentation ready? Brigadier? Not yet. I'm happy to go without a presentation. I can free roll, but I think it's very important that you follow and see what has been prepared. Okay. I think while they are still trying to pull the presentation through, I can maybe share a few insights around some of the observations. I think as Metropolitan Health, we've been in partnership with the South African Police for over a period of 9 years as your health risk manager. And there's quite a lot of initiatives and a lot of insights that we have learned throughout that partnership. Some of the insights that we've learned is what Dr. Foromo spoke about in relation to the implementation of the Comprehensive Health and Wellness DPSA framework. And one of the things that the South African Police Service do very well is to implement a comprehensive program. So you have social work services, you have psychological services, you have health and wellness, quality of work life, you have ill health requirement, you have sport and recreation. PaulMed spoke about the initiatives that we have around sport and recreation. All of those are core ingredients that can help you be actually one of the most healthier organizations in South Africa. Now, one of the things that we have picked up, which is a challenge generally in relation to implementing or deriving the full value of health and wellness program, is around measurement and engagement. Those two elements are two critical elements that usually render your efforts less effective. Now, there's a lot of things you can do to try and get people engaged, and there's a lot of initiatives that you can implement to measure the program. But how do you then implement that across silos? Because unfortunately, organizations are structured around units, divisions, and departments, and that on its own creates silos. So some of the initiatives that we want to share with you, which is part of the presentation, will show you how you can transcend those silos and be in a position to show better integration. I'm trying to look at the back and I'm wondering, why are you unable to fly the presentation? Is it sabotage? They will never win, General.
Mr. Manzin, you have blocked your laptop, but we've just received the email, so we're about to flight it. Ne? You blocked your laptop from memory sticks, but we have just received it through the email. So we're about to flight it, yeah.
Okay,
Yeah.
no worries.
Give us a second.
Okay. I think it's part of the security reasons working for a health provider. And also being around the police, so my laptop is intimidated, so it blocked its ports. Okay. Thank you. You can move to the next slide. So this is the slide I was talking to when I spoke about your comprehensive program. So Dr. Foromo spoke about these services that you currently have within your program. And what is important is, as a health provider, we want to encourage you to consider a few additional items that are important to make your organizational well-being effective. One of them being digital and enablement, the use of technology to deliver accessible healthcare. It's one of your biggest opportunity areas as a South African police. Introducing the concept of gamification. And the concept of gamification, I'm going to explain it later because it's part of the behavior modification research practices, but more importantly, incentives and rewards to drive motivation and change. These are the three basic ingredients of what you also need to consider as part of making sure that your health risk profile improves and you also have impactful solutions. Next slide, please. Now, we've looked at the slide. And there's that favorite word there for musculoskeletal conditions. So you and I, generally, we're not doctors, so we struggle with this concept. But what is important with this slide is that you can see that mental health, even from the health risk management perspective, it's still coming up tops in terms of prevalence within the South African police. Now, a lot of employees are reluctant to go and do physical, mental well-being support programs where they sit in front of a psychologist or a therapist. Now, that poses a question on its own and an opportunity at the same time. The opportunity is you can consider digital screening as part of your digital enablements to make sure that people are much more aware about their mental well-being. One of the simple things that you can do with, for example, technology like a cell phone is to do a facial mental health screening through an app. Can you imagine how many employees would reach if you were able to deploy such technology to all your employees? So those are some of the opportunities that lie in front of us that I think, as part of the deliberations of this conference, we need to consider and think about. Next slide, please. This slide is quite important. This is one of the useful tips that we've prepared to share with you, particularly looking at some of the research questions that this conference is aiming to answer. So if you're looking at the various work streams that will be facilitated, you'll realize that there's key elements that are emerging in those work streams. That is around changing behavior and improving integration. Some of the key insights that we pick up as a health risk manager as well as a wellness provider is that early detection and digital screening is one of your primary opportunities that you have that should be considered. You need to consider making sure that there's increased engagement and accessibility of well-being program. I think the lady who spoke in the video earlier from Katlehong Police Station, she spoke about EHWP not being visible, that they don't know that the service exists. So you need to look at various ways of creating awareness and making sure that wellness events are promoted and marketed. When you listen to the statistics from PaulMed shared that the engagement level is sitting at around 25% of, currently in South Africa, we have over 40% of the population currently engaged in a digital wellness program in our employee population. We've seen 20% cost reduction through these programs. I think it was GEMS that's reported it's in excess of 40%, it was PaulMed. Over and above that, on average, generally people spend between 8 to 10 hours of screen time every day. So this is one of our best friends, and we can use this to communicate and drive behavior. And then importantly, there's opportunities of digital screening. You will save cost, you will reach more employees, and you'll be able to implement digital and preventative programs to make sure that you prevent the onset of diseases and you reduce costs in terms of managing those diseases and also losing on those members that you have. And then I think that is the next slide. The next slide should be the last one. What is important is, of course, keeping in mind why you're doing all of this. You want healthier employees, you want to lower absenteeism and cap the losses of skilled employees. One of the statistics which I didn't share here is the high number of warrant officers that go through the ill health retirement. And that's your core, because that's where in lies your middle managers, experienced officers, and most of them are applying for ill health retirement. So through an integrated program, we would be able to cap that. And lastly but not least, you also want to have a culture of wellness within the South African police, synonymous to health and well-being, and members taking pride in their fitness, and the public taking confidence in their level of wellness and fitness in the public. And I think that it becomes a process of not one incident, but making sure that you synchronize a lot of your incidents so that you create that culture of well-being within the South African police. I thank you.
Thank you so much, Mr. Manzini. I told you you're going to enjoy that presentation. Now, we were all geared up for lunch, right? As I promised you. But because we're such a disciplined organization, when we get an instruction that we must continue, we continue. Isn't it? That's very good. The DNC just requested that we push one more presentation. We're not going to make it 2 minutes now, but this is a very critical one while the lunch is being prepared. We're going to invite to the stage Mr. T. Simane, and this is very critical in terms of our financial well-being. He's going to be doing a presentation. Can I invite him to the stage? Okay. Okay, let's invite Ms. Simane. Thank you. Come, let's put our hands together for them. They're from the National Credit Regulator, the NCR. I think it should be some useful information. Nsimane, Ms. Nsimane. Let's put our hands together for her, please.
Good afternoon. I am a bit quite, or rather short, but I will start off with a quotation that I got from one of my favorite authors. The book is called The Psychology of Money, which is one of our favorite subjects. I am accompanied by Ms. Jacqueline Baloy from the Education Department. Just to introduce myself, I am Tebogo Nzimane. I am the manager for the investigations and enforcement within the National Credit Act. Regulator. I'll just end off with the quote because I can't find it. I know that, okay, it's up. Right, who are we? We are amalgamated in terms of Section 5 of the National Credit Act. That gives us a constitutional mandate to ensure that there is a fair practice in terms of credit within the credit space of South Africa. Our constitutional mandate is very clear that we ought to do the following, right? To ensure that there is a promotion of inclusion within the financial sector. We would know that the previously disadvantaged, only credit was extended to a certain group of individuals previously. So with now the inclusion of this particular act includes every single person. It means that even an 80-year-old gogo can get credit, which, by the way, I don't recommend. The other issue that we do is that we will then promote enforcements and we also investigate. I will note that, Deputy Commissioner, that SAPS has been a very critical stakeholder of ours insofar as ensuring that we bring these cases to fruition. I can report that in the month of January alone, we had cases set down with the National Consumer Tribunal, and it was 42 set downs. In the month of February, we've got 43 set downs with regards to cases related to consumer complaints. So we are a regulator. We regulate the credit space. And I am not going to make this a act-driven presentation, because our presentations, in most instances, they are very engaging. They're meant for people to engage with us. One of the issues that we will touch on is the trends that we have noted within the credit space. And we all like our money, colleagues. Even at month end, there's colleagues who go home and they have nothing. And that is where the mental health is coming from. The minister also touched on the issue of mashonisa. We have a statistics department within the National Credit Regulator. And it has been noted that most government employees, if not SAPS members, actually go to mashonisas just to cope. The other issue that Jacqueline will touch on with regards to consumer education in her presentation is with regards to store cards. Why do you have a Woolworths, Truworths, and Edgar's card? That is what is going to cause depression. That is what is going to impede you now performing at work. You end up hating your job. You want to resign. You want to get your pensions so that you can quickly settle all these creditors. That is not the kind of environment that the National Credit Regulator wants to encourage. In fact, we are saying stop doing that. And the only way you can do that is to actually have a healthy relationship with your money. Saving is critical. You need to be in a position to save. I'm going to come in from the legal backhand of things because I like law, right? Yeah, it's my favorite thing to do, is to take people to jail. So we do have the Hawks, we do have SAPS as our stakeholder, very critical. We've worked with SAPS. We've also been invited to the Northern Cape, where most of our raids have come out from, including the Western Cape. The Western Cape, they are very naughty. They are very naughty because there's a lot of debt counselors there and there's a lot of unregistered credit providers. So I'm going to teach you a little bit about loans. When we check whether an institution can be investigated, we look at the loan. There's two types of loan. You have your short-term loan and your long-term loans. With your short-term loans, which is what I'm going to focus on, the loan that is advanced to you on a short term, the first interest that you're supposed to pay is 5%. Then any subsequent short loans that you make, be it with a bank, be it with a guy who's running a mashonisa business, 5%. Any other loans that you take out with that particular institution, it's supposed to be 3%. Right? That is your interest. So if somebody says to you, I am going to borrow you 100 rand and you must pay back 30% of that, that is what we call overcharging. We will investigate. We will shut down that institution. Also, check if there is a window decal. A window decal, it tells you that that institution is registered with the National Credit Regulator. If that decal is expired, you cannot take credit with that institution. it's a contravention in terms of the Act. So please, we need to ensure that we are very much aligned and also educated insofar as the credit space is concerned. I'm going to allow Jacqueline just to come in with the consumer education, and then I will round it off with the type of interventions or enforcements that we do within the National Credit Regulator space. Thank you.
Good afternoon, ladies and gentlemen. All protocols observed. My name is Jacqueline Baloyi. I'm from the National Credit Regulator, Education and Communication.
The new act, something called debt intervention, but unfortunately with the new act, we can't implement that. That would have helped a whole lot of people and would have given us a broader scope in order to investigate other issues as well. You will cover me. I will die at 120 and predecease, or you will predecease me. So it's the relationship, it's basic things like that we are trying to change the mindset of consumers. You cannot have 3 credit cards. Why? You are robbing Peter to pay who? Paul. So I'm going to leave off with this quote finally. It says the most important part of every plan is planning on your plan and not going according to your plan. I'm going to say it again. The most important part of every plan is planning on your plan and not going according to the plan. So meaning when you plan to buy a house, make sure that in your planning stage, you are saving enough money. Don't look at the end result of the plan, because you will go buy that Mercedes knowing very well that you are earning 15,000. And the Mercedes, how much is it every month? 15,000 plus what? Insurance. So don't focus. You need to plan the plan. So I'm going to leave you with that. Thank you so much.
Yeah, did you know that we had a credit regulator like this? Come, let's give them a general, I don't know, with all the presentations, I don't know if we still need to have lunch because of our BMI and all those other things that you were saying. So I'm not sure. But I was given strict orders by, may I request that please join, I think, room. I think it is Cedarwood. Can we just, yeah, this is like fly safair. You can't disembark together. You must wait. Presenters, yes. Okay, then all the and just bear with the generals and the brigadiers. They're much older. They take a little bit longer to wake up from their chairs. And they are very stressed because they're going on retirement. And they're not going to get anybody to salute them. Thank you. Okay, now that we've disposed of, okay, we've not yet, okay. I told you they take long, Brigadier Stratford. Okay, the rest of us, we will go to Pomolong. You know where that is? In Mpumalanga. No, I think we're going to go behind them, okay? Thank you very much. We will meet back at, let's make it 2:15, 30 minutes. Thank you. so that we don't waste time. Thank you very much. Is General Nkoa here? Can I request that we stand, please? Let's allow the acting DNC to come through. National Commissioner is here. Thank you very much. Thank you, Commissioner. Can we all take a seat? Thank you. National Commissioner, we have progressed very well on the presentation. Thank you, colleagues. Can we please have your attention? And in terms of our program, National Commissioner, we have taken presentations since the morning, post the address by the Minister and yourself. We had a presentation from the DPSA, from PaulMed, from GEMS, from Metropolitan Health, who was the previous health risk manager, as well as the National Credit Regulator. They were quite insightful topics, and we have a few more presentations for the rest of the afternoon. And with your permission, National Commissioner, may we proceed, or is that fine? Thank you. Colleagues, I hope that you had a good lunch. Did you? It was very good. It was a healthy, and I saw most of you were having a lot of veggies, and you took a lot of the good advice that we received this afternoon. So, before we proceed, may I request that we all stand quickly? There's something that we need to check. These are some of the leadership principles. So all of you are leaders in your own right, am I correct? Right, so all of us lead either in our homes, in our community, in our workplaces, or wherever the case is. So if you agree with the statement, or if you have come across this, or if you've experienced this statement in your personal career or in your life, you can remain standing. Alternatively, if you have not, you may please sit. Is that fine? You understand the rules? All right, so you are standing up because you have led a team in some part of your life, right? Okay. Continue standing if you have led a team through a tough situation. If you have not, you can sit. Okay? Remain standing if you have led a team through a tough situation. Okay, you can stay standing if you have ever managed a crisis where HR became the first responders. Do you understand it? Yes, if not, you can sit. All right, stay standing if you had to calm a tense situation between your officers and staff. Remain standing if you have had to calm a tense situation between the officers and your staff. I'm sure all of you, right? That is why you're still standing. Stay standing if you have mentored someone, listen carefully, who later became a leader themselves. Stay standing if you have had the opportunity to make an unpopular decision for the greater good. And lastly, you can stay standing if you believe strong leadership is the backbone for effective policing. So if you're still standing, you're a leader and you're making a difference in policing. Give yourselves a hand. So National Commissioner, we have many, many leaders here today. Thank you very much. Without further ado, I'm going to invite Mr. Mpilo from Pop Crew. He's going to share a short address with us. Thank you.
No, thank you very much. Stay standing if... Hey, can I just... I'm not sure. Receive special greetings from National Office Bearer of Pop Crew and greetings to the leadership of the police from the Office of the Minister, Office of the National Commissioner, DNC, and greetings to all the delegates and all protocol observed. Thank you very much. We have given them our presentation. No, I'm kidding. No, it's fine. We are privileged, and we thank you, comrades, for inviting us. The advantage of speaking, after the great minds have spoken, is that at least you get to deduce. When you speak, you just summarize and the thoughts of others. You also poke weaknesses. So that is a great advantage that we get to speak after very insightful presentations that were given today. But the danger of speaking after lunch, it is something else. It's something else. Now, this session, we must appreciate the office that has convened us. This is long overdue because we believe that our members are languishing not only on the area that seems to have been identified here, which is, I have seen the presentation speaking of a depression, they spoke of absenteeism, and so on. But there are many, many, many challenges which we believe that they are central to the scourge or unabated scourge of mental health, which has actually engulfed SAPS in the main. And that is a serious cause for concern from where we are standing. But there is furthermore, there is also things that must be identified as a part of a problem, which in turn results in our member being depressed. There is a phenomenon called supervisors or managers or those who are responsible to lead their subordinates. They are also a biggest problem in the mental status of those they are leading. And this is also one hard truth that sometimes we must confront. Because there's a problem of a superiority complex in the police, wherein a logic is replaced by rank. That is a big problem. And I think part of what we must do is to self-introspect. Actually, we must confront our own weakness. Actually, that is not my statement. I have stolen it from Dr. A.B. Kuma, who said, we must engage in the struggle against our own weaknesses. Then many challenges thereafter, you'll be able to attend to it and simply resolve it. But you have a problem of a person who's always right. National Commissioner, I do not think that it is precise to say comply and complain later. I'm saying if you are to drill down and challenge, there are some of the state, instructions that are given to members are not worth complying, or or a logical person should not at least follow such advices or rather commands. But I'm saying supervision is also one of the problems. There is let's promote people, because I think it's one of the issues. I'm just taking it from there, or rather, let me say at the Dendraft level. I'm just picking it to say people do not have money. Of course, the speakers have spoken. Our relationship, our questionable relationship with the rand, it's problematic as well. But I'm saying we have our own challenges. But there must be an admission that some of the challenges are not of our making. That is a very important point. I was going to clap hands for myself, but it's fine. So, I'm saying, thank you. I'm saying, comrades, I'm saying those who have an appreciation of where the department comes from, I'm saying historical appreciation of where the department comes from, where the department is, at least where the department is going. We have a responsibility, compañeros. It's not my word. I'm just stealing it from Fidel Castro. When I say compañeros, it's not my own lingo. I'm saying compañeros, we have a responsibilities, or at least a task, to wage and defend, at least in the immediate, our own lives, so that we will be able to defend for others. While I've spoken of Fidel Castro, he said, those who are able to fight for others will be able to fight for themselves when the need arises. So it's what is that poetic language? But I'm saying this is also something very important to note. It's something very important to note. But we must have an appreciation that as beings, as living beings, we are some form of a house of struggle. We are a house of struggles as as human beings. We must continuously engage in this struggle. But we are saying, as the struggle against weakness, our own weaknesses continue, the struggle for compassion must be intensified within ourselves. The struggle against lack of leadership must be resuscitated within ourselves. The struggle, against ignorance. Yeah, this one because I must disclose. This is not my own quote, struggle against the ignorance. It is the words of the leader of Frelimo, His Grace Samora Machel. He says we must continuously wage the struggle against ignorance. And there's a problem, as I'm about to conclude, there's a problem of people who believe they have arrived. Let me tell you something. Let me tell you, compañeros, because we ought to contribute here. And people, and my fear here, it appears, as you were saying, those who must remain, and so on. It appears we may be preaching to the converted, or to the people who at least are aware of the nearest shortcut if you are depressed and so on. And I think we have a responsibility as and when we depart, or at least the plenary must come up or come out with something that is at least it's chronological and worth following, and it's able to bring solution to the challenges that our people are confronted with. So, but there's a problem because I also do a lot of cases and challenges. We have a problem of a leadership as opposed to what you were saying. The highest number of people remain standing. And it is, unbelievable today. Because we really have a problem of leadership. Because a leadership, remember, we have many members who are committing suicide. We have many members who are depressed daily because of work. Not because of actual work, because of supervisors, so to say. So, because there are people who, they can't lead. And it is quite unfortunate. And I think as we resolve, we must also have a program which speaks to a leadership within the police, so that you do not entrust the life of those who are at least at the bottom of a pyramid to people who actually are in some form of a bondage themselves. Yeah. It reminds me of a story of a national commissioner of I read it, is one particular rapist. He says he raped, and then when he realized, hey, I may be in trouble if this woman walk out, then he says, no, the best thing is that while I'm sitting here, you rise up, and then you must bath, and while he's watching, you know how traumatic that is. Bath and put on the lotion, look presentable, look like nothing has happened, and then you can walk out. And that may be the status of what you are presiding over. A status of people who are actually going through a lot and are expected to actually fake it. Comrades, you can clap. We're here for that. But as I conclude, comrades, I am hearing the whispering. You know, when you hammer hard, you will be asked out of the podium, comrades. So, comrades, in his 18 Brumaire, the one of a very serious scholar, Karl Marx, has said something which speaks to the continuous struggle we must wage. He said, as I quote him, National Commission, and I believe we at least want to do something different compared to how things used to be done, and that's why we appreciate the office of that has actually convened us here. He says, man makes history, but he does not make it out of his own self-selected circumstances. He does not make it out of his own choosing, but he makes it out of the circumstances existing already, given and transmitted from the past, unquote. The advice Karl Marx was giving was that we must continue, because there's, anyway, even the Bible says there's nothing new under the sun. Whatever you are, this struggle, remember, is continuous. This is long overdue. It's just that we must just find a way to address it. We must go and wage this particular struggle. And as you do that, it's highly likely that you may bump into the spirit of Nelson Mandela. And it is highly likely that as long as you are committed, you are conducting this revolutionary activity of at least one, saving yourself, save those you lead, save your surrounding, you are highly likely to meet the spirit of John Langalibalele Dube. You are highly likely to meet, come across O.R. Tambo. As I sit down, he said, the same Tambo, he said, because anyway, in the olden days, they didn't have a privilege to do the media brief. When he meets people, he says, no. He said, look, he says, our people in South Africa must know that the struggle is on. Thank you very much.
Mr. Mpilo needs another round of applause. Thank you very much. Thank you for the inspiring message. Can we invite to the podium Ms. Mafoko from SAPO? Please welcome her with a round of applause.
Thank you, Program Director. I don't know if the mic is proper. Okay. Thank you, Program Director. The Minister in his absentia, the National Commissioner, the DNC, senior managers, commanders, colleagues, stakeholders, I greet you all. Program Director, it cannot be correct for us to come in a session like this and we are not honest to each other. I think if we've attempted to sit like this, that means we must break from what we used to be and be honest to ourselves. I think it will bear something good rather than coming here in this fashion and we walk out with nothing. So as we will continue with the 2 days from here, I think it's proper us to be honest on each other on this issue of EHW. National Commission, I will highlight some few issues from the previous speakers, including the National Commission. The National Commissioner touched the issue of the uniform. Employer, let's be honest with each other regarding the issue of the uniform. Just Monday, I met colleagues from Roslyn Pops. They were complaining about name badges. They don't have. They want us as union to come and address that. It cannot be correct. Can we rectify that? The DNC, the issue of great progression, it's a burning issue. Now it becomes a burden to us as labor. Can we address that as we progress with our responsibility? Can we deal with the issue of great progression? It cannot be correct we come and sit here and come with a nice document, whereas those who are in need, who are displayed here as the core of the SAPS, they are crying. Those who were displayed here, they are crying. Can we deal with the issue and be honest? Because a document will be just a document, and it will not reach who is supposed to reach. It will not be effective to who is supposed to reach. As I pass with that one, let me touch James. James, let's be honest. James, you are expensive. Can we be very honest with you? James, you are expensive. It cannot be correct. We sit here as if we are at the wrong meeting. No. I was sitting there at the back asking myself, am I sitting at the right meeting or I'm lost? Am I a traffic officer maybe that has been called out of this meeting to go and attend the right meeting? No. James, you are expensive. We are having a meeting at the PSCBC regarding the issue of James. We need to be honest with each other. Let's not sugarcoat the problem. Let's not sugarcoat the problem. If we sugarcoat the document that we want to come out with here,
so go to security.
it won't have a meaning.
Hi, how are you?
As I proceed, National Commissioner, with my presentation.
Nick? Hello, Nick.
I believe we've got commanders here. Commanders,
Mr.
can we adhere with the recommendation of a professional?
Yeah, just
EHW.
Just hold
As
on.
SAPU,
Can you see the screen
we've
being
mentioned
presented?
in so many
The
times
presentation.
that we want
Yes, I can see
EHW
it.
to be regarded as a profession
Just
in the
hold on.
police. The
Nick,
rank,
when
it
it's
gives
time
a
to introduce
problem
you,
to people
just
of
give us for a few
EHW.
minutes. Let him just call you.
Thank you.
It's connected. Sure.
So will I be
EHW
able to control the
professionals, they are
slides from my
complaining
side?
No, you
that
won't.
when they're
You won't.
supposed
This
to
side
go
will
and
be able
attend
to control it. So
a
what we are going
in
to
a
do,
rank,
we are just going to tell them to go to slide number 1, slide
he
number
or
2,
she doesn't
slide
want to
number
listen
3.
to
You
an
just tell this. When you finish
EHW
with the slide number
as a
1,
warrant
you'll
officer.
tell them go to
It
slide
cannot be
number 2.
correct.
Okay, no problem.
Yeah. Okay,
Unless
just
we
hold
break
on.
that
Just that
structure. And we call them professionals. They are professionals. We call them professionals. They also say, EHW personnel, we must care for the caregivers. They also say they need to be cared for also, because we know the ratio of those personnel is not how it's supposed to be or the ideal of what we expect it to be. Thank you. I will give an example of that ratio. An EHW personnel, there will be 7 with 1 car. One chaplain, when the chaplain is committed for a week arranging a funeral, the EHW personnel is forced to sit in the office. It cannot be correct. The facility is also a challenge. The EHW personnel, the facility that we as their patient, we go to them, is not correct or is not structured correctly. Some, they share office. When I go there as a patient, one personnel must leave and do what? And do what? The idea again of EHW to be at the station is also a problem because we've got this stigma with this profession. If it's based at the police station, the stigma will still go further because when I enter the police station, I'll
Okay, Mr.
already
Munya,
be regarded as somebody who's having a
I
problem.
think in the next 10 or 15 minutes.
So I think the issue of the facility.
Okay,
must
no
be attended
problem.
to.
So can you just
I was checking the
be ready?
effectiveness in terms of
All
EHW
right.
reaching
No, I will stay
people in terms of our
here.
I'm not free to talk when the work
Yes, it's
Bear in mind that
is where yes, at the canal. Of it of it to an HRM and as a class fall in love with it. Absenteeism to read it somewhere. Issue of recommendation of EHW of a member who is not feeling W, of a member who is not feeling well, who is having a chronic, let them respecting either. I don't know why. Feeling well. Because that he put a transfer last year. I think he said August. Call. What? Tswana people, they don't move from province to province. They sit in Northwest. National Commissioner, I'm appealing to you. That member is going through psychiatrist whatsoever until he reached me around November. When I procedurally check, I got resistance from commanders. Woo! Woo! People, there's no way we will have the document from here. But if I don't know, if we don't get it right, no. It will be just a document. That member, National Commissioner, I referred him to EHW with reference from the private doctor, psychiatrist, and whatsoever. It cannot be correct that members suffer from illness and we come here and sit here and think that we can do changes, but practically we don't do that. We must correct ourselves. As I conclude, Program Director,
move it.
the chaplain is only one mainstream when they are employed. We've got African, Muslim beliefs. So we don't know if is it a practice, but our country had changed. We had changed. We believe in so many things. We believe in so many things. Can the mainstream be changed? And we accommodate our African spirituality belief. I've got one colleague, when there was a time for a sermon for a chaplain to do, he will tell me straight that I'm a communist. I don't go to church. So I cannot be forced to go and sit in a hall and listen. It's not only him. It's only because National Commissioner, people are quiet. But us, the voice of the voiceless, will say it as it is. From what we saw on the videos, the trauma is deep, even with managers, National Commission. One social worker once said, unresolved trauma, when you are a leader, it will catch up with you. That is why we find leaders who want to do cycle. When I didn't receive a transfer, I also do to the rest as a commander. Because somewhere 20 years ago, I wanted to go to point A to point B. They didn't want, so I do it to somebody else. It cannot be correct. Can we correct ourselves? Unresolved trauma is very dangerous. Can the profession be regarded as such, as a profession? Let me close by one of the motivational speaker of all,
Mr. Munya.
Yes.
Miles Monroe.
Yeah, please
One
try
of
to stay in the meeting.
All right. I don't know what happened,
Vision is the source
but
and
I
hope
was
of
in the
life.
meeting.
The greatest gift ever
Okay,
given to
because your
mankind
time is now.
is not the gift of sight,
Oh, I'm supposed to
but the
present
gift
now.
of vision.
Yeah, soon.
In the next coming
5 minutes.
Sight is a function
Okay,
of
no
the
problem.
eye.
We are just waiting
Vision
for the last
is a
speaker.
function
Now it's
of the
finishing.
heart. Eyes that
Okay,
look
just hold
common,
on, Mr.
but
Mu.
eyes that see
Okay, no thanks.
are rare. Nothing noble or not with on earth was ever done without a vision. Close quote. I've got notes. National Commissioner, Labour, when we've got a platform, we've got a platform. Can you bear with us? Another quote from Miles Monroe. Open quote. The heading of that quote is, they damage you intentionally. Then it further says, discover into purpose. Intention. That's all.
Mr. Munya. Mr. Munya.
Hello.
Mr. Munya.
Yes, I'm here.
Yeah, you're up next now.
You are next
All
now
right.
in seconds.
No problem.
Okay.
Without disclosing my union membership, can we please give a round of applause to SAPO again, please? Research report. May I please welcome to the stage the Acting Head of Research, Brigadier Dr. Mokhari, please. Please welcome him. I'll also like to invite Mr. Garrett Newham. You can join us on stage, please, sir. Thank you.
Good afternoon. I submitted my presentation. I'm not going to take you long because I will be speaking on issues that affect us as the organization. I think we can just skip the first one. It's clear, straight to the point. Let's move to the next one. What is actually contained in the presentation are as follows. I will deal with the introduction and background, the research process that we applied in conducting the study, the problem statement. I won't dwell much on the problem statement. I'll also talk on the model that we actually we've utilized to measure the staff morale, demographic factors, findings, and recommendations. Thanks. Let's move to the next one. In terms of the background, introduction and background, Colleagues, we conducted a study in 2023. This was not the first of its own. In 2021, we conducted a morale survey in the SAPS, looking into what is actually causing members to have, for argument's sake, low self-esteem, what are the challenges or salient factors that affect members to perform their constitutional mandate. In 2021, colleagues, we conducted the study. It was during COVID. We got a very low turnout because of COVID. Members were working from home. Other speakers, they've already spoken about issues of resources. We are aware that the members at station level, some they don't have internet connections, they don't have emails, and it's a challenge on its own. So how we communicate with them utilizing AI is also a challenge. So in 2021, we conducted a study. Again in 2023, we conducted a study. The final one will be conducted in 2026, which will be presented in 2027 financial year. These studies, we are conducting them in line with strategic management, component strategic management, because they emanate from the strategic plan 2020-2025. So basically what we're actually looking at in terms of measuring the staff morale, there are 4 factors that we're actually looking at. The first one is SAPS members' morale on the extent to which the police live up to its values. That's the first part that we're looking at. Next.
Hello?
Yes, sorry about that.
The next one, we're looking at
There was a bit of
perception on the extent to which
clash,
SAPS
so
cares
there's still
about
one speaker left.
the well-being of its employees.
Okay, so what time am I presenting?
They spoke about the issues of
How long?
EHWs, but I won't dwell much on that. The third one, we looked into the issue of ethics and integrity within the SAPS. We know that community members, they are
I don't know,
doubting
can you
our
just give us
we don't have a
20
good relations
minutes?
with community members to whatever
20 minutes.
The last one, we're looking at
Yeah,
the
roughly
SAPS
between 15 and 20.
Okay, so I have another meeting that is starting at 4.
policies that we are actually utilizing national instructions. One would argue that
Okay, let me just.
1 day absenteeism.
So because I had scheduled in time that from this meeting, after my 30 minutes presentation, I would hop to the other meeting.
Can you just speak to President?
We actually look at
But give it 10 minutes.
performance indicators so that we know where we are standing as
Hello?
the organization.
Hi, Munya.
Yes.
Yes. There's another person that they have loaded on the stage, and the person is running the presentation. So I'm not sure how long can you wait, or can we reschedule
After conducting
the presentation?
I was ready, but it's only that I need to speak to my guys at head office. So they had booked me for 4.
Members complain about
But they say this one is finishing. Okay, because they say the person must finish in 10 to 15 minutes.
Okay.
Yeah, so the program director is here listening to me now to say they're going to push this presentation because he's here. Even when there's a need for further clarity, he can still entertain the concerns.
Okay. All right.
Yeah, please, we really pardon us. It's another, yeah, he says 3:45 latest.
Okay, no problem.
Sorry about that, ne? All right. But I'm not going to get out of, yeah, yeah. So what do we do? Do you suggest that we get out of the line or we hold on? I was suggesting that let's not pull out of the link. Yeah, please stay on the link because it can even be earlier than 4:02.
cares about is well-beings. In 2021, it was 22%. It moved to 40% in 2023. In terms of ethics and integrity within the SAPS,
Hello, Mr. Munya.
18% in 2021, and we've seen
Hello.
Oh, he's still here. Yeah. Okay. There's a guy from TNS, Munya. He says, please hold on a little bit longer for us. Not that long, but the program director will make sure that the speaker who is on the, yeah. Okay. All right. Okay. Okay. Sorry about that, Munya. It's fine. It's fine. I know it's a bit of an it's doing that. Hi, Munya.
Command and control should actually take the center stage.
Yeah.
In 2021, it was 50%.
I think it was buffering earlier, but it's back on again. It's still here.
In 2023. Thanks. Next one.
Can you repeat that?
Next. In terms of the methodology that we utilized,
Yeah.
we're conducting applied research as opposed to basic
Can you
research
hear
in the
me?
organization.
Oh, okay.
It's research
Can
for
you?
the
Yeah,
organization.
but it's very
For the
soft to speak.
organization.
It's
So
quite
we
soft for me.
actually utilize the quantitative approach.
Hello?
Quantitative meaning
Yes, yes, we can hear you now.
engage with
So the
Yes,
program
I can
director,
hear
utilizing
you.
the intranet.
yes, okay, it's
takes
fine.
to
He's
distribute
gone back to the
questionnaires in
stage.
various
He's gone back to the stage to try and sort
station
out
level.
the guy on stage
That's
to
what we
maybe
actually
limit
did.
his
In terms
time.
of the design, we used a descriptive one. In terms of the population, all members were invited to participate. In terms of the total, in terms of the response rates, we actually utilize a formula that is called it's called the concurrence formula, wherein we're looking at the number of the confidence level at 95%, margin of error at 5%. We're looking also at
Mr. Munya, please do fast 10
and
minutes.
also the required sample. So basically what you are seeing there in terms of the 4,122 is the number that we're able to get in terms of the
Hello?
completed questionnaires. You're asking yourself, we're 180,000, so why did we actually arrive into that number? Colleagues, in
Mr.
terms
Katumba.
of research, what we do, participation is voluntary, which is something that is important. But however, there was an increase from 1,552 to 4,122 in 2023. In terms of data collection, I've already spoken about it. In terms of ethical considerations, they were clear. We do not coerce members to participate.
Hi,
But the onus is
you left the link.
assist us in terms of finding solutions to problems that exist internally. In terms of the questionnaires that we actually utilize,
Oh,
it was
then
effort,
somebody
and
is
it was
okay.
found that it was
Let's
valid and
reconnect
reliable.
then so that somebody
Next
can.
one, please.
He says he needs to
I
be
won't dwell
accepted
much on
again
the
because
problem
he got
statement.
out of
I've
the
already
list.
indicated that. Next slide,
So
please.
they are going to get.
Okay, colleagues, in terms
He's
of the
going to
modeling,
try
we
and connect
actually use
again.
10 assessment categories
Yes,
to measure
you are
morale.
already
So we had
waiting.
54
It's on the list.
statements,
On the list.
meaning that there were 54 questions that
Let's
we
see.
asked in terms of the 10 assessment.
It doesn't show yet.
If you check the one is job satisfaction, I'm not good, I'm colorblind. Job satisfaction, that is on top.
Because I can't accept you from mine as well because I'm an invitee. Here it doesn't show.
In terms of
Can we
employee
refresh
supervisor
and do
relations,
it
we
again?
look at that.
To
Employer-employee
out of.
relations.
Monia, can you get out
Communication
and join
was
again?
also addressed. The issue of career opportunities and advancement, we also look into that. You'll see it when I present the
Can
findings.
you exit
Recognition
and log again?
well-being of members, SAPS values, and SAPS government framework. So we utilize this model to measure the morale in the organization. We don't say morale is low. We only say morale is low after measuring these 10 category statements. Okay. Next one, please. In terms of demographic factors, colleagues, in terms of gender, we had more males participating in the study. Of the 4,122, we had 2,124 that participated. In terms of age, it was between 41 and 50 years. In terms of population, more Africans participated. In terms of education, highest level of education, the highest was matric. In terms of years working the SAPS, 11 to 20 years. Rank, it was surgeons who participated more. In terms of numbers of years in the service, 11 to 20 years. In terms of provinces, Gauteng had a highest number of participation. In terms of station area, we had more urban stations that participated, but it will also talk to the issue of resources, because you go to other areas, they don't have resources. You can skip this one because the previous slide was captured everything. Move to the next one. Next, yes. In terms of the findings, colleagues, let me be clear. We utilizing a barometer to assess whether we're moving to the right direction or the wrong direction. The one on top with the speedometer will tell us where we are at. In terms of the assessing job satisfaction, colleagues, let's concentrate on the red ones, the one on the bottom. Out of the 4,122, we've asked a question, I'm satisfied with the working conditions under which I work, only 42.4%. In terms of I have adequate resources in order to perform my duties, only 40% agreed with the statement. The rest is self-explanatory, I won't dwell much on them. The next one. In terms of trust level, like I said, that in 2021 it was 12%. Let's look at whether we trust each other as colleagues, even where we are seated. You look at the bottom one, I trust my colleagues. it's at 51, let me say 52%, meaning that there's that portion that doesn't trust each other. Let's move to the next one. In terms of supervisor relationship index barometer, I'll only concentrate on the last part. Currently, my supervisor listened to my suggestion. It was at 49%, meaning that half. Previous presenters, they've spoken about the issues of trust, but yeah. The next one, please. Next slide, please. In terms of open communications barometer, we're looking at information is openly shared between management and employees. Only 47% agreed with the statement, which is a call for concern. I'm not going to focus on the top, but in terms of the barometer, it's seated at 53%, of which is also a call for concern. Next, please. In terms of career opportunities and advancement, it's red. It's red, power outage. Let's look at all the statements. The first, go back, please. Okay, we're looking at the well-being of employees. The barometer is also red. I feel that information with HW will be treated with respect and confidentiality, 48%. Employees are keen to engage in well-being initiatives, 40%. Supervisors understand the importance of this one. The governance framework is at 46.7%, 47%. I'll only concentrate on the last items, the last two items. SAPS has effective corporate government framework that promotes fairness and transparency and accountability, 40%. SAPS has a sound corporate government framework that boosts my morale, 40%. Next, please. This one is also red. I'll only concentrate on the red part. It's about the service values. We're looking at it. The barometer is at 47.2%. I'll only concentrate on the red one. I know that time is on my side. I'll only concentrate on the four. SAPS members provide a responsible, effective, and high-quality service with honesty and integrity, 49%. SAPS corporate well-being with the community at all levels, and government's role players are in order to achieve the mission, 48%. SAPS members always use their power vested in them responsibly, 48%, civil claims. SAPS members always use power, okay, SAPS members live up to their values, 45%. The last one, SAPS is committed to develop and skill all members through equal opportunities, 41%. Next, please. Okay, this is a summary of what I've actually presented, but the red ones are the ones that we need to actually prioritize them, the issues of recognition and reward, career opportunities and advancement, and well-being of our members. Although it's also important that the government, corporate government framework needs to be at an acceptable levels, because if we're dealing with civil claims, it means that someone is not doing his job. Whether it's issue of burnout, whether it's issue of comply and complain later is another issue. But the other ones, we are actually doing far much better on them. In terms of the overall morale, like I said, it was 27% in 2021. It stood at 49.5%, meaning that there's half that doesn't agree, or there's half that is actually demoralized in the organization in terms of the total overall population in the SAPS. Next one, please. Okay, we've asked two open-ended questions. Whether, the first question that we asked, how would you rate your level of morale currently? Remember, the study was conducted in 2022-2023 financial year. If you look at the first one, very low morale, 25%, low morale, 39.6%, high morale, 26%, very high morale at 7.1%. When we ask, how would you rate motivation in the organization? Again, in terms of the ratings, below average was at 44.4%, and also on average, 51.9%. Next, please. In terms of emerging themes, so we ask, what is it that we need to do as the organization to improve our morale? Members raise the following. Resource, we need to have adequate resources. We need to curb corruption, nepotism, political interference, and there's also a smaller one, Police Act members are saying that we are overlooking them in terms of promotions because you apply, you reach a ceiling, and you can't go anywhere else. 25 years in one position, but it's a story for another day. But these are the issues that members were raising. Favoritism, appointment issues, we need to look into those. So these are the issues. Next one, please. In terms of the areas for improvement, the one on red are the ones that we are saying if we don't address them, morale will go down. Promotions, issues of salaries, issues of promoting fairness, issues of resources, and also review of policies that are stagnant. Let's look into that. The moderate ones, we are saying, okay, recognition, yes, but commanders need to listen to their members. The issue of training, how many of us have underwent training that is fit for purpose? We need to look into that. The issue of motivation, motivate an employee when they are doing a right thing, we also look into that, but it's at moderate. And also the issue of combating corruption, because if we don't combat corruption, our relationship with community members will be stalled. In terms of the one on low priority, the issue of treatment, respect, overtime compensation, communications, and employee wellness. We're saying it's at low, but we need to ensure that in order for us to be able to work effectively, you need a healthy, healthy employees. Next one, please. I'm done. Next one, please.